This presentation is over fractures of the elbow joint. For the anatomy of the elbow, we will be focusing on the bony anatomy, which is comprised of the humerus, the radius, and the ulna. Pathology. The first type of fracture is a supracondylar fracture, and that is a fracture at the distal end of the humerus. There's three types of fractures that this can cause. Type 1, the humerus is not displaced. Type 2, the humerus is moderately displaced. And type 3, the humerus will be severely displaced and this commonly requires surgical interventions. Pathology. The second type of fracture is intercondylar fractures, and that is a fracture of the medial and lateral condyles of the distal humerus. As you can see in the picture below, it can happen in 3 different degrees as well. Pathology. The third fracture that occurs in the elbow is the radial head fracture, and that is a fracture of the proximal radius at the radial head. Pathology. The last type of fracture to occur in the elbow joint is the olecranon fracture, and that's a fracture of the olecranon process of the proximal ulna. Mechanism of injury. Supracondylar fracture. The mechanism is falling on an outstretched elbow or a direct blow to the elbow. Intercondylar fractures. The mechanism is a heavy impact to the hand or elbow. Radial head fractures. The mechanism is falling on outstretched arm. Olecranon fracture is falling directly on the tip of the elbow, or a direct blow to the tip of the elbow, or fouching as well can cause this. Signs and symptoms of a fracture in the elbow joint are commonly pain, swelling, bruising. The patient heard and or felt a pop or snap at the time of the injury. They could have possible obvious deformity, and they possibly will have numbness or weakness in the elbow that radiates down the arm. Another important component to look for in the signs and symptoms is the fat pad sign. This is the visualization of a lucent crescent of fat located in the olecranon fossa on a true lateral view of an elbow joint, with the elbow flexed at a right angle, indicating an elbow joint effusion crescent of fat located in the olecranon fossa. The patient will typically have to have an x-ray to see this, and as you can see in the picture, it does occur anteriorly and posteriorly. The special test to find a fracture includes the percussion test, which is tapping of the bone, which will produce a force that is transmitted along the shaft of the bone, and this in turn will cause pain at the site of the actual fracture itself. ATs can perform the percussion test, but if that is confirmed, they typically need to send for an x-ray. The x-ray at the bottom left is a supracondylar fracture. The second one is an intercondylar fracture. The third is a radial head fracture that had to be surgically fixed, and they put a pin in to fix that. And the last picture is of an olecranon fracture. Predisposing factors of fractures include age, sex, osteoporosis, chronic medical conditions. Certain medications can cause this, nutritional problems and not eating as you should. Physical inactivity, tobacco usage, and alcohol usage as well. Recognition. Fractures of the elbow commonly need to be recognized with the use of medical imaging, along with completing a proper evaluation and use of the special tests such as this percussion test. Differential diagnosis for fractures include sprains of the ulnar collateral ligament, annular ligament, or of the radial collateral ligament, muscle strains, or dislocations or subluxations. Management and treatment for these fractures includes protection, optimal loading, ice, compression, elevation, splinting, the use of non-steroidal anti-inflammatory drugs, possibly surgery if the fracture will not heal on its own properly. And then if they do require surgery, that will require the use of pins and plates to reduce the fracture to allow its optimal healing. Referral. The certified athletic trainer will refer to an orthopedic physician for medical imaging and treatment. If the fracture will require a surgical intervention, they will refer them on to an orthopedic surgeon as well. Immobilization for fractures includes casting, splinting, or bracing. Prevention of fractures includes maintaining strength and agility by exercising regularly, wearing protective gear during sporting activities, learning proper techniques for your sport, and taking steps to reduce your likelihood of falling or learning how to fall properly. Mulligan technique. There is no mulligan techniques for fractures. For my PCOT analysis, the patient was an 84-year-old female with a history of rheumatoid arthritis. For the intervention, it was a fixation of the fracture was performed through a standard dorsal approach surgery. The comparison, there was none. The outcome, the radiographs demonstrated early consolidation across the fracture site due to the incooperation of the patient. The time frame was 9 weeks. It was 3 weeks prior to surgery and then 6 weeks post-operative. These are the references that I used to complete my presentation.